thank Prabhudayal, Komal, and Raju of Lupin for arranging this. And another new style which Lupin has started, I feel, is focus group discussions. In this competitive era of so many webinars happening, it's difficult to mobilize too many doctors, but it's one way. It's focus group and more intense discussion, more exchange of ideas is always welcome. And I immediately agreed for this because not only with due to relation with Prabhupada, Lupin, and Saurabh and others, but I'm very happy to share any of my thoughts on high dose statin therapy because I feel this is grossly underutilized in day-to-day clinical practice. Wherever there is an opportunity, I always feel like expressing my views and exchange ideas so what others feel about it. And indeed, I'm very happy to share the same platform with Dr. Shailendra Singh sir today, the senior most cardiologist, and we had very fond remembrances of sir. We found River from student days, and thank you, Lupin, for making this possible. And we welcome all these other junior cardiology colleagues who have joined from various parts, not only from Hyderabad, Vijayawada, Vizag, Cochin, Trichur. And again, it's at least, if not for knowledge exchange, we get to know each other. It's always good to be part of any such meetings. And before I go on to the talk, I thought we recently had this interesting case. Some of you, Charan Singh, sir, with vast experience, must have seen, but some of you might not have seen. We call tendon xanthomas always, but we got this 12-year-old boy who had this classical xanthomas here, and here, and on the uh, even the knee joint. He had very high familial hyperlipidemia patterns. His cholesterols were in about 700 plus, and LDLs were about 400 plus. And this had angina. We did angiogram, triple vessel disease, which was not suitable for PCI. Then we had to send him we were forced to send for surgery, left main triple vessel disease. Now, with great difficulty, we are trying to mobilize PCSK9 injections along with statins to this patient. As of now, he's doing all right. Just to recapitulate, these four are very important subgroups of patients in which we know high dose statins would do a good thing. Just I always keep remembering, compare this with playing cards King, Queen, Jack, and Eka. So basically, the king indication of a high dose statin is basically atherosclerotic cerebrovascular disease. And if that already patient doesn't have a disease like CAD or peripheral vascular disease or carotid disease, if anybody has LDL cholesterol of more than 190, again the benefit by high dose statin. If you don't have a disease, you don't have high LDL, but you have diabetes, again that is again an indication for treating with high dose statin, because all these patients, if they're not taking, were landing in trouble. And then if you do not have any of these, but atherosclerotic cerebrovascular risk calculator, which ACC/AHA predicted, if your risk of getting into trouble is more than 7.5%, again people say you get benefit by high dose statin. So it is. I thought it was apt for us to recollect these four important indications for high dose statin. And then this is a risk calculator. I won't go into details. Many of you must be already aware, but it gives us a fair amount of idea that what would be the risk of getting into trouble, what is your immediate risk of 10 years, and what is your lifetime risk of getting into trouble. All of us actually can check your levels feeding in it, and many of us could fall into this. So we won't realize it unless you do it. So it's important to use that app which is there in any of these smartphones now. High intensity statin therapy, many of them still continue to use small doses of simvastatin and very minimal doses of rosuvastatin, atorvastatin. But what we all need to realize is rosuvastatin 20 or 40, atorvastatin 40 or 80. These are the only two drugs which satisfy the high intensity statin criteria. That is, they have the capacity to reduce LDL cholesterol by more than 50% of the pre-existing value. Other small doses do not do that job. And then there are some risk enhancing features which are recently described again, apart from the standard risk factors. I thought I would just mention it. Metabolic syndrome, chronic kidney disease, which we commonly see, and then chronic inflammatory conditions and premature menopause, these post hysterectomy ladies, and South Asian ancestry itself is now reported as a high risk race. Indians do fall into it. Then other aspect, especially when you're discussing with rosuvastatin regarding it, is always this high sensitivity C-reactive protein comes into picture. Then elevated lipoprotein small a and ankle baker index. These are again called as risk enhancing factors, not direct risk factors. So if you are careful and take all the recommended drugs, we can decrease the problems happening by 73%. So how the main thing which is happening is statins are poised to perform greater wonders in 21st century than antibiotics did for infectious disease and H2 antagonist and PPIs did for peptic ulcer in 20th century. So these are the wonder drugs which do a lot of good. Many of them have worry in using this statin because of this worry of side effects. If you see, these statins are 100 times safer than diabetic medications, which are more for poor from hypoglycemias, and 10 times more than aspirin, which is commonly used. So I think safety of statin is established. Coming to the topic which we wanted to discuss today is basically some of these goals which are high risk in secondary prevention are redefined after this European Society guidelines came recently. So this concept of very high risk is introduced. Previously, we used to say low, moderate, and high. Now we identified very high risk subgroups who are getting recurrent events. So if you see this, anybody who has familial hyperlipidemia, of course, that we are not discussing here, but severe CKD, long-standing diabetic with target organ damage, and diabetics of more than 20 years duration fall into very high risk category. And all these need to be treated aggressively if with high intensity statin. The previously we used to think that anything less than 70 milligrams were all right. Now this for high risk category, now it is decreased to 55 milligrams per deciliter, or more than 50% reduction of the pre-existing value, whichever is least. So now we should forget the 70 value and come down to 55 milligrams per deciliter value. And lower is the better anyway. The high and moderate, as we go down, the categorization slightly becomes less. What about our Lipid Association of Indian guidelines? This again, they adapted the same. And very high risk, we went further down to 50 milligrams per deciliter as per Indian guidelines, because we Indians are tend to get into trouble more, and ethnicity itself is high risk. So we need to target such low LDL levels. How it is possible, we'll come to see. The previously, this recommendations were not there on ezetimibe and PCSK9, but latest 2019 recommendations made that very high risk subgroup of patients, if you are not able to achieve with high dose statin alone, you need to use a combination therapy with ezetimibe or the PCSK9. These are all class 1 indications. So that is very important for us to understand and take the help of these additional molecules if required. And if anybody who gets into recurrent events within 2 years, he gets into recurrent troubles, again he falls to high risk category. And not only ezetimibe and probably PCSK9 inhibitors could be taken into medical treatment. And for such individuals, the ultra low reduction or very low LDL reduction of less than 40 is what is recommended. In which individuals? Patients who are experiencing recurrent events within 2 years. So that is a indication where we need to go down further of that value. So coming to the ACS and lipids, we know that they play important role, and a lot of additional benefits are reported here. The lower the level LDL values, the better it is. That is what is came out in all these multiple trials. And then now that we know that only high dose rosuvastatin and atorvastatin are the statins, two statins which can perform this high intensity reduction, then which statin out of these two to be selected? Most commonly, this is the doubt which many younger colleagues have. We can discuss further on it, but we are discussing about today's molecule rosuvastatin novostat. The advantages and fit is obviously it is highly potent. I think none of the cardiologists, any one of us, have any doubt regarding the potency. That's how the rosuvastatin 10 will be equal to atorvastatin 20. And this is because of highest affinity for HMG-CoA reductase inhibitors. All these statins we know are coenzyme and HMG-CoA reductase inhibitors, and this has maximum highest affinity and better liver selectivity and less side effects. That's how. If you have a patient who is tending to get into side effects, probably this would be preferable. And drug-to-drug interactions are less, and this is less lipophilic than atorvastatin. That's why it is able to do the job. If patients who have elevated CRP levels also, it is supposed to reduce this risk significantly, as noted here. There are a lot of trials which came with rosuvastatin on regression of atherosclerosis. Atorvastatin, though it was good, but it was not able to cause ultra low LDL reductions of less than 40. That's how it was not shown much in regression, though there are some studies. But a lot of studies with rosuvastatin, Orion, Cosmos, Asteroid, many of these showed regression of atherosclerosis by intravascular ultrasound, OCT, and now this study initially showed by carotid ultrasound. So all these now show that it is very potent and effective on the rosuvastatin. Then if you see this advantages, where you have to choose of rosuvastatin is, as I mentioned already, this is less lipophilic, drug to drug interactions are less. But if you see the LDL cholesterol reduction, is much more with rosuvastatin compared to atorvastatin. And other advantage is in India, we do see a lot of patients who have low HDL. The increase of HDL again is better with rosuvastatin. And then triglycerides obviously both perform okay, but HSCRP elevation patients, again, there's a lot of data tested with rosuvastatin. And that's how this molecule is found to be more potent. Obviously, there are some comparison studies. We don't have need to go into details. Lunar compared with atorvastatin 40 and 20. Obviously, the rosuvastatin scores over atorvastatin 80 in reduction of the LDL cholesterol. This we know, but other thing which we also need to understand is the HDL increase is also better with the rosuvastatin compared with atorvastatin. That's how in Indian scenario where you find low HDLs also this could have some additional advantage. This is Centaurus studies, another study which compared atorvastatin. Then obviously the power of rosuvastatin reduction, there's no doubt in it. Other important subgroup of patients which we see in day-to-day practice is diabetic dyslipidemia patients. 92% of patients with diabetes have dyslipidemia. I would go a little faster because all are cardiologists here and can have some more discussion. 9 out of 10 will have dyslipidemia. And even in the Indian subgroup of patients which is seen, this India study, ICMR done, low HDL cholesterol is quite common. And that's how I feel this could be more useful our in Indian subset of patients. So this discussion point is basically statins in diabetic patients. Then how to use which statin. That's how the advantages are there. The worry of statin intolerance. There are some discussion questions. I think we'll just I'll finish off the other presentations and I'll go on to those discussion questions in the end. Other important aspects of statins which are studied is during PCI. So when we were knowing that before PCI, if you give this molecule, there's additional benefits, decreases myocardial damage and injury. But this was because of various other additional non-lipophilic benefits of the statins, which could be seen. If you see this statin pretreatment before PCI produced actually less elevations of CRP, and then MACE levels at 30 days was also significantly less in high dose statin. And then initially it was tested with atorvastatin with Armada ACS trial, and again later in Korean study, rosuvastatin was also seen to have the similar effects. The less of myocardial injury, periprocedural myocardial infarctions which we get during PCI, and again the event rates are also significantly less when we use the statin loading before PCI. Then this is what is shown in these various things along with HSCRP levels which are reduced, but even the periprocedural events are less. This is a large review meta-analysis which came in European Heart Journal showed that usage of this molecule significantly reduces not only periprocedural MIs, but events are also less on follow-up. And some of the studies also showed even in the stable heart disease patients while doing PCI, this could be beneficial. So we need to discuss how many of us are using this high-dose statin in the pre-procedure, both in acute ACS situations and stable situations. That is the second discussion point. First one we thought was diabetic dyslipidemia. Second is the pre-PCI and post-PCI. And that's how we have strong data to show that if you use that periprocedural MI should be less. Another interesting thing, actually, how this is utilized, vastly underutilized, is basically because of worry of statin side effects. How we should address this, we'll again discuss. More such education things could help. Other interesting thing, actually, which I came out in, this is not given by Lupin also, is this Prato ACS study. This is rosuvastatin. Another interesting concept which I studied is when initially we had a worry whether usage of rosuvastatin will produce more of CIN and CKD injury, creatines rising. But wherever the statins are used, they come as winners. Even this in the study compared with placebo, usage of rosuvastatin showed less worsening of less incidence of CIN, contrast-induced nephropathy, after the procedure. See this in AKI in the controls it was 15%, in rosuvastatin it was 6%. So it significantly decreased. So this is another additional usage point I feel where you have borderline creatinine values, diabetics, and you're going for PCI. I think we should definitely use this high dose statin pre-procedure. Adverse events obviously were less of a diabetic scenario. Just I thought before I conclude, this is my thought process of which statin to be preferred in which clinical scenarios, and all of us can opine and discuss further on it. Obviously, all of us agree that high dose intensive statin therapy is only rosuvastatin and atorvastatin, not the other statins. I think there's no controversy in that. And rosuvastatin in day-to-day practice, we prefer generally And not because we are discussing only about it. Atorvastatin also, it has its potential, preferable probably in acute coronary syndromes and post-PCI interventions before. But now we have data coming up that rosuvastatin is highly potent, and familial hyperlipidemias, what case examples, tendon xanthomas, and what are shown, I think this is a molecule to prefer. And diabetic dyslipidemia, which is again very common in an Indian subset, where you have low HDL, high triglycerides, and high LDL cholesterols. Again, low HDL increase is better with rosuvastatin. This is another scenario where we can prefer. When lower than LDL, lower LDL preferred, this is because of recurrent events happening in spite of PCI. That scenario what I showed, if somebody is having recurrent events, you are actually wanting to go down to LDL cholesterols of less than 40. Again, this high dose statin should be preferred. ACS pre-PCI, not the regular ones, or pre-PCI, and then you also have data in heart failures and secondary prevention, some of this with rosuvastatin coming up. Other clinical scenario where we change the statin is when somebody is not able to tolerate atorvastatin, you can put them back onto rosuvastatin because little of less side effect prone because of less lipophility. That's what is preferred in this. Whereas atorvastatin, you have more strong data in acute coronary syndromes, post-interventions before, and then also for primary preventions, hypertension, diabetes, alone you have data with atorvastatin, and maybe interchangeable when somebody has a problem with rosuvastatin. So these are some of my thoughts. I think we can discuss more. And before we conclude, we all should be doing good job to the patients by preventing the disease. As ancient Chinese, now we don't like this Chinese word itself. We are allergic to it because of COVID. But superior doctors prevent the disease. Mediocre doctors treat the disease before evidence. Inferior doctors treat the full-blown disease. So we should not be just aiming to put stents after disease is full-blown, but we need to prevent the disease by using proper dosage. And not only primary prevention, even secondary prevention, at least we can avoid getting into trouble again and again. So these are some of the things which I covered in the discussion. I think we can discuss more, and we can have discussion thoughts. So discussion points could be, now can we get everybody in the screen? Technical team? I think they're ready.
Yes, sir. Yes, sir.
Yeah. And
Dr. Jubil Matthew, sir, also joined, sir.
Okay. Yeah. Welcome. Good evening. And some of these, which statin to prefer in which setting, I just shared some of my thoughts, sir. What are your thought process, Dr. Sreenivas, sir, in this?
Sir, can you stop sharing the slides?
Okay.
Yeah, then all will be on the screen.
I think you have to unmute everybody, huh?
Yes, sir. But yes, sir. Now this okay.
This one minute I will take.
Yes, sir.
Yes.
Prabhupada should excuse me.
Yes,
lot of young doctors, sir.
Yes.
Lot of young doctors. I said this COVID challenge for cardiologists or any doctors for that matter. Lot of us do get lot of free time, but many of them are watching TVs, Amazon Prime, doing nothing. So I thought it's good to convert our free time to productive time. That's why.
Hello, can you hear me?
That's a fantastic, great sir, initiative, sir.
TCT time, I thought either you should publish, write, improve your skill, or then at least become more healthier or fitter.
Absolutely, sir. Absolutely.
So I just post this, and I'm already getting some of the submissions, some good paper publishing, and then some of the improvement of skills, and so a lot of doctors also becoming more fitter. I want all the youngsters to take this seriously, the COVID challenge of TCT.
Yeah, Zoom Hello, can you hear me?
After I stop sharing, I think you can comment.
Yes.
Now I stop sharing.
Yes, sir. Now all are visible, sir.
Shailen Singh sir ka nahi aa raha? Yeah, I think now I think everybody is coming. Hello.
Yeah, hello. Yeah. Somehow we lost the video.
Yeah, now we got it again.
Got it.
We are able to see madam now.
You are able to see me now?
Yes.
You can hear me?
Yes.
Yeah, let me talk to you about something which is, let me talk you something about latest about what is rosuvastatin's and how is it better than atorvastatin. What is the latest is that what is known as cholesterol efflux. Do I have 2 minutes? I can
No, take your
explain.
time, sir. What is there? Please present, sir. Please tell. Go ahead.
Yeah, no. There is a lot of controversy regarding this HDL. Now, HDL in Framingham trial showed that low HDL is a risk factor for increase in the coronary artery disease, and high HDL is protective against coronary artery disease. Then numerous trials were done, like for example, the CETP inhibitor trials like Illuminate, trial. All these trials, they gave CETP inhibitors. The HDL increased by 50%, but the coronary events did not reduce. Then they did 2 trials with niacin, AMI, and HDL on Mendelian trials were done. They showed that high HDL is not protected. There was doubt why Framingham trial there was protection. So they looked at specific function of HDL, cholesterol efflux. So those patients who have high HDL have high cholesterol efflux showed protection against coronary artery disease. So this cholesterol efflux, what is cholesterol efflux? What happens is in atherosclerotic plaque, the macrophages contain the lipid, contain the cholesterol. So when the HDL comes in contact with this, the HDL is efflux occurs from the macrophages into the HDL molecule, and the HDL takes this high LDL cholesterol to the liver to be excreted in a protein called ABCA1. When rosuvastatin is given 40 mg for 12 weeks, they have shown that ABCA1 levels are high within the plaque. So when ABCA levels are high within the plaque, it is promoting efflux. Now, this is the mechanism. But is there a clinical study? Yes, there is a clinical study. It is called Yellow Trial. In this Yellow Trial, what Annapurna Kidney did is, she took patients she's an interventional cardiologist. She did angioplasty for patients. And in the non-culprit lesion, she did FFR. And those lesions which showed FFR less than 0.8, she did intravascular ultrasound of that lesion and also did infrared spectroscopy and measured lipid-rich core. How much lipid-rich core is there? So she called this lipid-rich core index. And she measured this at 4 millimeters and 10 millimeters within the plaque. And then these patients were given 40 milligrams of rosuvastatin for 17 weeks. After 17 weeks, these patients were taken back to the lab, and then infrared spectroscopy and IVAS was repeated. And they found there was 21% reduction at 10 millimeter and 22% reduction at 4 millimeter within the plaque of the lipid rich, suggesting that cholesterol efflux is promoted by rosuvastatin. Therefore, this is one drug that has shown not only regression of atherosclerosis as in a steroid, but also has shown cholesterol efflux does occur, and the cholesterol efflux is promoted by rosuvastatin.
And in some of these indications, that is the pathogenic mechanism sir has highlighted, and now it shows that that's how it is more potent, and regression studies of atherosclerosis is more coming with rosuvastatin. And in a day-to-day clinical scenario, sir, how much percentage of patients you use this rosuvastatin? How much atorvastatin?
I'm
not able to hear you.
Clinically, I mean, when we see clinically, the trials show there is not much difference between rosuvastatin and atorvastatin. And also, there are a few trials with atorvastatin showing regression, little bit less than rosuvastatin. But clinically, there is not much difference between rosuvastatin and atorvastatin. But this is a point to be considered in future, probably rosuvastatin causing more regression of atherosclerosis and therefore better to use. The data on rosuvastatin, atorvastatin came first, and therefore the data in ACS patients is abundant with atorvastatin. But there is data coming with rosuvastatin also in ACS. I think you can choose either one of these drugs for treating ACS patients.
And only thing what is important is they have to use the right dose. Suppose if they are using atorvastatin 80 milligrams, probably rosuvastatin 40 milligrams, or if rosuvastatin 20 sometimes could do that job. But if they are using less dose of atorvastatin, that does no good actually. If you are using atorvastatin, you should use
Yes.
higher dose 80 milligrams, and rosuvastatin sometimes 20 and 40 may be okay. But if you are using atorvastatin, at least proper dosing is also important to be kept in mind. That is it. I think in diabetic dyslipidemia has shown that many of the times, along with familial hyperlipidemia, this more wherever there is more powerful, potent lipid reduction is required, I think you prefer this molecule. I think let us take opinion from all other doctors. Dr. Ullas, can you hear us?
Yes, sir.
So, what are your patterns of practice in your day-to-day patients?
Sir, basically, if you ask me, my percentage of use of atorvastatin or rosuvastatin is more than 80% patients I am using atorvastatin itself for the time being.
High dose statin, at least let us say, is usage is better. No, now it has improved compared to what it was before. All of us now are comfortable using high dose statin, or do you have any doubts of using high dose statin?
No, basically we are using high intensity statin for all of our ACS patients.
Yeah.
So if an ACS patient comes to the ED, he will be going with a high intensity statin. Preferably atorvastatin 80 milligram is the current practice that we are following.
And pre-PCI, are you using high dose statin now?
So for all primary PCI, definitely we are using high intensity statin. Atorvastatin 80 milligram is the current practice. And for our elective angiograms plus ad hoc PCI, many of the patients will be on statin. If they were diagnosed with a case of chronic stable angina, many of them are on statins. May not be on high intensity statin, but if it is an ACS, definitely the patient will be on a high intensity statin.
I think there's nothing wrong even in stable patients. If you're doing PCI, even for stable patients, nowadays not to miss out antiplatelets, we give an extra dose of antiplatelet tablets. Like that, similarly, you can also give an extra dose of high dose statin, be it 40 milligrams of rosuvastatin, 80 milligrams of atorvastatin. That's a good practice where all the interventional cardiologists should adopt, I feel. And any other points you want to mention before we go on to other doctors, Dr. Ullas?
Sir, I want to hear from the seniors that how diabetogenic is statins.
Yeah. I will address that. Let us hear others worries on that aspect from other cardiologists too. Dr. Ramakrishna, do you want to say? Is he there? You have to unmute all others, Komal. Please unmute all the doctors now.
Yes, sir.
Yes, sir.
Yes, sir. Yes.
Ramakrishna, sir.
Is there? Ramakrishna is there?
Yeah, he's there, sir. He is there, sir.
Yes.
Yeah,
Yes,
Dr.
sir. Am I
Ramakrishna,
audible?
sir. Yes, sir. Yes,
Yeah.
sir.
Please go ahead. And
Sir,
now
yes,
you are comfortable using high dose statin, or still continues to get into practice of 10 milligrams, 20 milligrams of statin?
so all our patients receive high dose statin, 40 mg of rosuvastatin or 80 mg of atorvastatin. Initially, all acute coronary syndrome patients, we are giving high dose only. In general, after the first 3 months, probably we are trying to reduce the dose to 20 or 40, 20 of rosuvastatin or 40 of atorvastatin. That is my practice, sir, because many patients do have some constipation, other things. Of course, myalgias is very less. Other problems I have not seen much, but many patients do have this constipation.
Most common complaints which we want to reduce is because the cost. Dr. Prabhudayal and others should note this. Suppose if the 40 milligrams of rosuvastatin, 20 milligrams of rosuvastatin, 10 milligrams of rosuvastatin all come at one price, and patients will get the best of the maximum high dose statin therapy. I keep telling to all the companies, because it doesn't really matter if you put little more dosing of statin, but patients will get a long run a lot of benefit. And if any company comes forward with this pattern of putting a common cost for any dose of statin, because 10 milligrams also many times you would sell at lesser price, but it evens out. I think the doses of prescriptions could go up, and that's how the patients could get the benefit out of this high dose statin therapy. And very less sometimes worry of diabetes incidence prone, and sometimes muscle complaints are there in some very few percentage of patients. But what I would like to mention is only when you're using a combination therapy, like we do see some patients with high triglyceride levels, and in our country, when you are combining high dose statin with triglycerides, like reducing drugs like fenofibrate, I think that's where we need to be a little more careful to prevent the side effects, and also careful monitoring of SGPT-OTs, and more of myalgias could happen at that particular point. But if you're using only high dose statin with ezetimibe, which is a good help now, when you're not able to achieve, that is less worrisome. And now the more potent PCSK9 also has come. That is not a point of discussion now. But ezetimibe again is a safe bet to combine if you're not able to achieve those values. I think with that, now Dr. Jubil Matthew.
Yes, sir.
Yeah. What is your practice now, current practice of using statins? What is the commonest dose of statin which is given in your practice?
Usually in primary PCI, we give the higher 80 milligram statin, atorvastatin usually, and in 40 milligram rosuvastatin also we use, and that is rare. And but in all case of elective PCI, we use 80 milligram pre-dose, the previous.
I think another point which you would also consider is we were worried to use the statin pre-procedure in CIN, contrast in the CKD patients where borderline creatines were there. Now the trial showed benefit actually, much less incidence of increase of creatine rise. So another area where this could benefit pre-procedure is wherever the patients have little borderline creatine values like 1.5, there again you should definitely use pre-procedure statin. It goes a long way along with hydration. We have no obviously less loss of contrast. Along with hydration, I should you take the benefit of the statin loading, be it atorva or rosuva, but that particular trial was done with rosuvastatin 40 milligrams. I think that is again a point for us to remember. How many of your times in your clinical practice you have to decrease the dose of statin because patient complained of something?
Rarely, sir.
So that's important. Many of the times, if you recollect, frankly, many less times we decrease the dose of statin because of some complaint. I feel probably most common complaint against the companies is obviously they can't afford to do everything for us. You expect a lot of things from them. But if the price is not a problem, many of the times incidence of usage of high dose statin will go away. One common entity if you have to see. The other worry of side effects is less, and many of the times patients keep requesting. That is another thing. And in a chronic, how many of the times you use in diabetic dyslipidemia subgroup of patients, we do get patients nowadays. Now all the cardiologists should become comfortable with diabetes therapy. That's what people say. And many of the times we do see endocrinology colleagues not using statins. So how commonly you come across that?
Usually we use reduced dose. If triglycerides are high, we will combine with the fenofibrate, but moderate 20 milligram rosuvastatin with the fenofibrate.
Yeah, many of the endocrinology colleagues only use fenofibrate. That is a little not to be encouraged because any statin, any lipid therapy has to be statin plus. I think all of us understand now. I think even in patients who in which triglycerides are high, diabetic subsets, we definitely should use statin, and maybe in that subset, little potent ones are better. But we only using fenofibrate, aim high trial and others did not do any good. So I think any treatment has to be statin plus, and then if still high ezetimibe, then other thing is PCSK9. We also have saraglitazar, other drug which has come up in high triglyceride patients. Sometimes we use it. I think Dr. Shashank, in your practice, oh, how many percentage of patients you do use high dose statin now?
Almost all interventional patients using high dose statins.
Prabhudal, your job is already done, man. All the doctors are already using high dose statin. That's that you have chosen
3 months because of cost or some other issue.
See,
20 rosuvastatin or atorva 40 increase.
Same complaint.
Same.
Anyway, I feel strongly because all the companies, if you unanimously decide that high dose statin and the regular dose statin cost should be same, then it goes a long way for patient benefit.
Yes.
Right? The other point of discussion, Komal, you had anything you want to say anything?
Yes, sir. One more point in continuation with this. So you are using high intensity statins in all your ACS patients, but post PCI, how long do you continue this high intensity statins, sir?
normal day-to-day practice, because of cost issues,
Yes.
because the events are more in the first 1 year, we
Yes.
definitely tend to use it for 1 year. The later on, if somebody creeps, you might decrease. But what is recommended is, if your
As per-
patient develops has two successive LDL cholesterol values 3 months apart with less than 40 milligrams percent deciliter, there is some point in decreasing dosage of statin. But in all other subsets where the levels are high, you should give these tablets lifelong, and as high dose statin also for getting the benefit. You need to convince the patient saying that as long as you take the tablet only, there will be benefit. If you don't exercise, you can't have all the benefits. Same is the case with this tablet too. But only problem is if you have to do a cost effective analysis or patients cannot afford. So maybe after 1 year or so, you tend to decrease. But first 1 year, you have very high events. Restenosis rates were also commonly high. So that's where till that time, you definitely tend to use high dose statin. Later on, unless there is some side effect or some problem to these patients. Other thing which you should rule out is any secondary causes which can produce problems like hypothyroidism, rheumatoid arthritis, or CKD. Some of these problems which could be associated leading to side effects, we need to rule out. But if patient is able to tolerate well, I think you need to give this lifelong. Now that's what is the data. But at least for an year in Indian practice because of cost issues. What do you say, Dr. Shailendra, sir?
I think you have to give for 1 year for lifelong, because you are able to hear me.
Yes, yes.
Yes, sir.
You have to give lifelong, because now the latest is, like, for example, if you want to get mortality benefit
Yeah.
from statins, you must use for at least 5 years.
Uh,
So if
and
you
the more
reduce LDL to less than 50 milligrams for about 5 years, then you get a mortality benefit. And if they have shown latest evidence is that they are describing LDL levels, that is LDL in milligrams per year. So they are telling that these if LDL levels are low consistently over a period of 5-6 years, then you get 40% reduction in the event. But if the LDL levels are high in between, then you don't get 40% benefit in reduction of the events. Therefore, this LDL reduction should be as low as possible and consistent till a new platform comes which will reduce LDL levels to very low levels lifelong, like they are doing now, genetic modification of PCSK9 gene with a CRISPR-Cas9 platform, so that one injection, the LDL levels are reduced to 20 and they remain 20 throughout the life. But as for us now, we have to give statins for a long time.
Yeah, I think that message is very clear. As Sir also told, all of us agree that the longer that you give it, the more beneficial, and the earlier they start, again, the benefit could be more. And especially long-standing diabetics, again, we should not neglect, because as the diabetes duration increases, then patients will have more trouble. To your point of Ullas, your worry of getting into trouble with increased sugars, I would just address. Any other doctors are left, Dr. Prabhu?
Yes, sir. They are there, sir. They are there, sir.
No, I am not able to see. All the doctors which I've said, I've just covered, I think. Any other doctors which are not able to see on the screen? Anybody is missed out?
Dr. SPK Ramakrishna, sir, you told.
I spoke already, Ram.
Yeah, sure.
Yeah, all are there, sir. All
Yeah.
you covered.
All of it.
Anyway, so now basically what we need to understand is, be it be diabetes treatment, be it be coronary artery disease treatment, be it be hypertension, any treatment, Ullas, we all know that we have to decrease mortality in patient. We are not worried about little sugar value which is happening this side, because the commonest cause of death which happens even in diabetes is not because of sugar rise. We all know that because of events, cardiovascular events which are happening. Having said that, if you have to see what is the risk of increase of sugars little compared to what is the benefit which is produced, this is actually a lot of randomized meta-analysis is done in this subgroup after Jupiter. Jupiter is the one which first raised this concern of little increase in sugars after the usage of statin. But even in the subgroup of patients in which the increased sugars happened a little, and compared to those, even in that subgroup of patients, mortality was less. Sugars were a little more, but even that subset of patients in Jupiter in which sugars were increased, still the mortality and events were less with statin. And then we went on to further see in which subsets of patients, how much is the risk benefit. That came to be 9:1. One time risk of little increase of sugar, but 9 times the beneficial effects. So now I think this worry should not be there. Even if the sugars are little increasing, we need to convince patient that it still produce benefit in those subgroup patients. Probably your point is well taken. If you're dealing with a scenario of metabolic syndrome where sugars are borderline, where you tend to make them into diabetes, something like that you feel. But anyway, that fellow would develop a diabetes over a period of time. That is also we need to understand. What these drugs are doing is probably little removing that hindrances which are happening, and there could be little increase. But mortality patterns and events are less even in that subgroup of patients in which sugars are little high. I think 9:1 is the benefit, even if you consider that sort of thing. This is shown in the meta-analysis which is published in before, after Jupiter and other trials. I think that worry also should not be there. Other is second worry is a worry of a lot of people say that rhabdomyolysis and statin-induced problems, they are much very less minuscule. And even if the myalgia sometimes could be described with these patients, but all myalgias you should not mistake as the statin problems only, especially when the patient complains of some pain in finger or one cough. That is not statin induced myalgia. Generally, statin induced problems could be bilateral. I think this is statin intolerance app. All of you can download it from smartphones. That clearly shows anything which is unilateral, anything which is poking, anything which happens only for few times and disappears. All these are not statin related problems. And with this minimal complaints, you should not withdraw the statins and avoid the benefits of high-dose statin to these patients. So we need to make it doubly sure whether it is happening only because of statin before we withdraw statin. And even in subgroup of patients in which you are trying to do it, you are trying to decrease, step is to decrease the dose of statin to half or switch to other statin. That's what I was mentioning, interchanging of statins. So suppose patient developed some problem on atorvastatin, switch to rosuvastatin and vice versa, and still try to give the benefit of this high-dose statin, even if you are getting into some sort of minor side effects. And even if you stop it and you can again try to re-challenge and see, because the benefits of giving statins are enormous. So I think that is the recommendations of things, statin intolerance and myopathy or some muscle complaints and some of the side effects like sugars. And Shashank, anything else you wanted to tell? You unmute everybody again.
This role of statin in CKD patients, how they are more they are benefit, because nephrology people don't agree, because pathophysiology is different. They feel high dose is not required in CKD post intervention.
That's what, anything you do, CKD is a big
Because
subgroup
more
of patients. That's the beauty of cardiology.
Yeah.
We treat patients, the patient become all right, and we want them to go happily walking and live normally. The CRF patients is a difficult subgroup anyway. They are on dialysis, they are little. We keep joking from 6th floor, top single rooms, they gradually get worse and worse and come to general ward, and the families get ruined. Unfortunate disease it is. So whatever you do, it is very difficult to produce the total benefits in CKD. Understand the benefit may not be as much as in a patient who is not with CKD, but even in wherever you challenge the statins, I think I tell the same with ACE inhibitors. Wherever you challenge whichever subset you challenge statins, they come out as winners. CKD also, the trials done showed, initially they said there's a worry of progression of creatinine and the patients who had go. Even in that subset, again, it showed benefit and less worsening of GFRs with statin usage. I think there also benefit is not as much as in a normal individual, but still, because the risk is more in CKD, you need to understand this again conceptually. If you're dealing with a subset of patients who have maximum risk, the benefit would be also more. So that way, because the risk is more in CKD, the benefits also will be there. May not be as much as in the patients with the normal values because of various things. But the worry of not giving statin because of renal failure should not be there in our mind, because it is no more problematic. Maybe initially when rosuvastatin was launched, that worry was there of a little increase in creatinine and proteinuria, which is there, which is later disproved. So that's how many people are comfortable using atorvastatin little more commonly than rosuvastatin in CKD. But some statin, you have to use it. I feel definitely benefit should be there even in that subgroup of patients.
Can I add a point?
Yes, please.
Yeah.
Hello?
We are able to hear you, sir.
Can I add a point?
Thoda
Yes,
dur
sir.
rahiye,
Yes, sir.
The CKD now, EGFR between 30 and 60 is included in high risk category
Yes.
for statin dose with the LDL reduction up to 70 milligrams in European guidelines, which are given in 2019. And EGFR less than 30 is included in very high risk,
Right.
where you have to give high dose statin with statin value, LDL value of less than 55.
And how many of you believe this ultra low LDL reduction now, which is coming up? The latest buzz is previously we said the lower is better. The later we said lower is only better. Now we are seeing the lowest is the best, because now ultra low LDL reduction is a concept which is happening. Okay. So this terminology is very important for us to understand. Previously we said the lower the better. Then we said lowest only is the better. Lower is only we should achieve. Now we are saying ultra low LDL reduction. That is very important for us to understand, because regression of atherosclerosis happens only when LDLs go down below 40. Please note this, all the people, because many of the trials which were done before, it is very difficult to show regression of atherosclerosis. But now we are able to show regression of atherosclerosis, because now we have very powerful drugs called PCSK9 inhibitors also, which could decrease LDLs to less than 40. Now you will find a regression. There is a long, Eugene Braunwald actually predicted with inclisiran therapy, which is likely to come up, then we may much usage of stents and other procedures could be much less in interventional cardiology too in future, because the progression atherosclerosis could regress significantly. All the moderate lesions could be again benefited and could go into mild lesions. So all of us need to understand this ultra low LDL reduction concept. But agreed, it is not easy to achieve those levels. It's easy to say that you get less than 40, but it's not easy to achieve in many patients. But all of us should try to do it, especially in young patients who get recurrent events and somebody has suffered more than one event after PCI. These are the subgroup of patients where we should target ultra low LDL reduction. Any points of disagreement in this? Anybody doesn't agree on this? Prabhuday, Lupin, if you have to get something, no? Because we keep discussing
Yes,
administrative
sir.
things.
Yes, sir.
Sir,
Yeah, Dr. Kamal would like to.
yeah,
please.
sir, regarding this ultra lipid lowering, so as you rightly said that guidelines are saying this target of 55, or in the event it's more less than 40. So in actual practice, how low you go in for the achieving the LDL target, sir?
It is easy to say here in this webinar sitting that you should get less.
Yes, sir. So
but
in practice,
that is why the concept of 50% reduction is introduced. Initially, we had only cutoffs. Okay, cutoff values of less than 70 were taken. In not many patients, we are achieving it. So that's why, not to disappoint doctors and patients, this concept of ultra low LDL reduction, high intensity statin therapy came, where you actually want to at least decrease by 50%. Okay, if that 50% is less than the 55, that is well and good. But many individuals, Indians, we see levels may not be high, but still they suffer events. There you don't go by absolute values. Still, whatever is the lowest, you have to achieve that. So either 50% of the pre-existing value, or this target which we are fixing as 55. So whichever is least, you are supposed to achieve it. But with high dose statin and probably combination with estimate, you could achieve it. But in Indian subgroup of patients where levels are not very high, still you should not be very happy. The high dose statin benefit should be given, because these are subsets of patients, young patients, recurrent events. These are the patients could benefit with high dose statin therapy. Whatever lipid levels he had, even that LDL cholesterol could be 50 in that patient, but still it has produced an event in that patient. So that's how we need to target to reduce and probably give high dose statin therapy longer. And for at least in clinical practice, we follow it as said at least for a year, but we benefits will get it if we use lifelong. So the lower the better, Komal.
yeah, thanks, sir. So you said as lower the better, longer the better, and earlier the better. That's what, sir.
It's
At
also
cardio,
better for Lupin.
Now the ultra lower.
yes.
Yes, sir.
So at a cardiologist level, you all are using high intensity statins, but sir, at a physician level, especially, there is a underutilization of high dose statins, maybe therapeutic inertia or anything. So how to tackle this issue, or what is the cause? I mean, if the patients go for the follow up to the physician, they reduce either the dose, or if they shift to the combination, they also reduce the dose of statins. So your views on this, sir?
Yeah, they generally is seen because they are worried about this problems, this WhatsApp and other things. No, anything which dramatizes becomes very popular. The bigger man, I don't want to take names, he says highly against this. If you save one life, it is very difficult. It's not easy to save one life, but these people will keep on criticizing and do a lot of that thing catches up very fast. So physicians and other things are worried about the side effects and producing problems. That worry should be removed. And second thing I would say is not to be biased towards physicians, because physicians generally treat hypertension, diabetes, and less of this ACS and post-intervention patients. Many in my interventional practice, I never keep patients or follow up. Generally, I try to send them back to physicians so that they should send us new patients. But many cardiologists keep following their patients themselves also. Then that's how the number of patients who are going after the event, after the procedure to physicians could be less. That's how the overall incidence of high dose statin could be less in physicians' usage compared to cardiologists. But many of them are becoming wiser now. The only single point of problem now in our country with high dose statin usage, Prabhudayal and others should note, is the cost issue. If a cost can come down, lot of physicians will use more high dose. And this worry of high dose statin usage is gone from cardiologists. None of the cardiologists had any issues in using high dose.
Absolutely.
And gradually, with doing more programs like that, physicians also would remove that fear. But this negative criticism, rather than that, you should circulate something positive which has happened with high dose statin therapy. Like
But still, I believe, sir, this inertia is at the physician level, still it is there, as you rightly said, because more aggressively we need to promote this. Absolutely.
Yes. And something positive about high dose statin therapy, how the patients improved, less, how they benefited, all that can be circulated.
That outcomes can be discussed. Absolutely, sir.
I think, what is the time now? How much time more we have, or are we coming to close?
So some more points are there. Can I ask, sir?
Yeah, please go ahead. I thought we have finished.
Sir, 2-3 questions. So, sir, next question is regarding the combination therapy. So, guidelines recommend that after once the patient is on high dose statins, reevaluate the lipid levels after 4 to 6 weeks, and if it still on high dose statins and not achieve the target, then add ezetimibe or PCSK9 in such patients. So in clinical practice, are your patients get controlled on high dose statins, or in how many percentage of patients you add ezetimibe in such patients, a combinations therapy or PCSK9?
Actually, ezetimibe became little out of popularity once the previous studies which showed that there's not much of mortality benefit, right? But now again, after the latest trial which came with the combination of the simvastatin, the original statin with this ezetimibe, then that also produced mortality benefit in that trial. So that's how ezetimibe is again come back into daily practice. And not many ezetimibe drugs are available. I feel only ezidoc of lupin is available many times. Many of the ezetimibes are withdrawn, but it's good that it should be made available freely up there. And ezetimibe definitely helps in some patients where you're not able to achieve the values. But whatever is the said regarding that, we are not aiming only for the digital values of LDL cholesterol to less than 40 or 55. We need to give high dose benefit of statins in spite of achieving those target levels. If you have to see in clinical practice, in less than 50% of patients probably would achieve those by statins alone. But I'm not talking this of subsets of patients who get into ACS and MI even with normal lipids. In our country, we do see young patients get into trouble even with low levels of cholesterol and normal lipids. So that is a different subset. But if you have a high lipid levels before and on follow-up you have used high dose statin, I think about 50-60% will be able to achieve those levels. But still significant number of patients, you need to take the benefit of ezetimibe. Now I started using aggressively PCSK9 inhibitors because anybody who can afford, now the PCSK9 inhibitors, that I was wanting to advise Prabhudayal on that. If your lupin wants to get something new, you should get one. That other competitive molecule has come with evolocumab. You can come with alirocumab or something. And in further, if you can come with inclisiran, I think Novartis is already getting inclisiran to the country. And that will be a major game changer. That will elevate the status of company also. Get such molecules.
Fantastic. Sure, sir. I will pass it on.
Sure. Thanks, sir. Thanks a lot.
What is your opinion, sir? Shailen Singh, sir, about percentage of usage? In which percentage you get the target levels? She's asking.
Yeah. I think it is very important that high dose statin be used. Now they have given one of the recommendation in European society is irrespective of their LDL levels. If the patient has ACS, you have to give high dose statin.
That's what I was mentioning.
Yeah, that is one thing. Second thing is, I think we should aim at the lowest LDL levels that is possible, because they have shown in, like, for example, in Odyssey trial, that the alirocumab, when they gave over high dose statin, when they reduced the LDL level down to 20, 25, then there was further reduction in the events.
Yes.
So there is incremental benefit with LDL reduction even below 40. So that's why it is very important to aim at the lowest LDL level you can achieve with statin in a patient. And you add ezetimibe if they are above 55, add ezetimibe. These two drugs can be easily given. Only other drug that cannot be given not very easy is because PCSK9 is, the 1 year course of PCSK9 is costlier than bypass surgery. So that's why I think it is difficult to use PCSK9 in most of the patients. But if PCSK9 becomes cheaper, or inclisiran comes, like for example what you said, siRNA, this will be only 2 injections a year, once in 6 months insulin.
Yes.
So that's why that will be very useful, I think.
I think one thing which this ultra low LDL reduction PCSK9 did is remove the worries of low LDLs in our brains. That is gone now. Previously, many of us were worried, not me, but many of others were used to get worried about carcinomas happening with LDL, too much reduction, all that. That is gone now. So we are very clear that ultra low LDL reduction is also safe.
Absolutely.
Go ahead. Any other points, questions?
Yeah. So next is regarding diabetic patients, like recommendations are there in diabetics with very high risk. They are saying use of high intensity statins, and for primary prevention also in diabetics above 40 years, they are saying use of moderate intensity statins. So your takes, how you use statins in diabetic patients?
That's what I was mentioning. It should be used.
Yeah.
Diabetes is now proven as the coronary artery disease equivalent. So how you treat a patient of CAD with MI, you are supposed to treat with diabetic patients too. And we need to understand that sugar values are not that important, though borderline sugar. I'm not saying too much uncontrolled sugars are good, but even if sugars are a little higher, it is not as problematic as if lipids are higher in these patients. So a lot of patients die because of cardiovascular events. So that's how we need to treat how sugar lowering drugs are important. Similar important, or if it's not less or little more important, is usage of statin therapy in this. And the more longer the duration of diabetes in a patient, the more benefit it gets again with the statin. That is because risk is more. Wherever there is more risk, the benefit will be also more. And if the diabetic patient has a high lipid levels, that is a definite synchronon indication for rosuvastatin. You can't achieve very less reduction with atorvastatin. So if somebody is a diabetic and has LDL cholesterol of 190, 200, and total cholesterol of more than 300, there's no point trying atorvastatin in that subgroup patients, because they will definitely need more higher power potent rosuvastatin. If somebody asks me what is the indication for rosuvastatin, not only because of this Novostat meat, what I'm saying is anybody who has very high lipid levels, I think we should first think of rosuvastatin, then atorvastatin.
Yeah. And sir, regarding high intensity statins used in diabetics, so in such patients, which intensity you are using? I mean, it depends on the risk stratification. How do you decide of use of high intensity or moderate intensity? I mean, clinically.
That's what I said. Longer duration, that is, if diabetes of more than 20 years duration has come into very high risk according to ESC 2019. And even if 10 to 20 years has come into high risk. In these both subgroups, we need to give high intensity statin therapy. The only moderate intensity statin therapy comes where the diabetes duration is less and patient did not suffer an event already. Suffered an event, any form, again he goes into high risk category. So patient who has only isolated diabetes of shorter duration, that's where you use moderate intensity statin. But all other subgroup of patients, long duration, already suffered an event, then you go into high risk category where you need to give high intensity statin.
Yeah. Thanks, sir. Sir, next question to all panelists regarding we are doing LDL levels in all dyslipidemic patients, but we say that Indian dyslipidemia is different, and now guidelines are also focusing on other biomarkers like ApoB or LPA, so or HSCRP. So, are you using these other biomarkers also in your patients, and in which patients are you using?
Sir, you want to say?
Yeah, I think HSCRP has been given as a risk enhancing factor. Therefore, if you check, there is nothing wrong. If you have a patient who is young and who's got borderline cholesterol, then do HSCRP. If it is high, it becomes a risk enhancing factor, then it's more in favor of statin. Now, the LP little a is very important. LP little a is that is so shown to be very high in Indians. And LP little a, if it is above 30 milligrams, then you should think of considering giving high dose statin, because LP little a is an independent risk factor apart from LDL, and there is no drug that reduces LP little a except PCSK9. Niacin should not be used. Therefore, only PCSK9 is the drug that reduces LP little a, and therefore all patients who have LP little a above 30 should be given high dose statin.
How many of the other doctors are using Ullas? Do you check HSCRP regularly?
Not routinely.
I think what most of the doctors follow, Dr. Komal, is wherever you find a standard risk factors, then we don't keep on searching, because patient is already having diabetes, hyperlipidemia. Even if it is there or not there, still we give high dose statin. So in the subgroup of patients where there are no obvious risk factors, like sometimes metabolic syndromes, patients who have little triglycerides elevation, we don't have any obvious smoking, other things, there probably we keep on searching for other things. There I think we use LP little a and HSCRP more. But in ACS type of scenario, somebody who is suffering recurrent events also, we tend to see look any other cause, and that's another subset where you might see HSCRP levels. But if you have to treat a heart failure patient, other indication where HSCRP has some role, at least the trial showed, is if a patient doesn't have obvious CAD, obvious ACS, but he has heart failure, LV dysfunction, is another subgroup of patients where you test HSCRP, and if levels are high, they could also benefit by usage of statin. Not high dose maybe, but even little dose of statin could benefit even in LV dysfunction type of subsets. Those are some of the indications I think in which we test. But by and large, wherever you do a investigation, it should change the treatment patterns of patients or give some new information. Just for the sake of sending it, you are not supposed to send it. If you are changing the therapeutic treatment with some investigation, there is a point in spending money of these patients. So LP little a was out of popularity because none of the drugs were significantly reducing. Now we have a good option of treatment with PCSK9. That's how I think checking. We are doing one trial with Novartis of LP little a with a newer molecule, and that's how that things are becoming popular. So in other words, HSCRP we tend to see in where there's not obvious in the risk factors already. I think any of you want to, Dr. Jubil, anything you want to say here? I think same.
Same.
Yeah, Ramakrishna is not there. Shashank.
Thank you. Dr. Shashank, sir.
Since routinely we are not doing these things like this.
Yeah.
Obviously, another risk factors are there.
I think it is 8:45. Anything else, Komal? Tell me.
No, sir. That's a last question from our side. So, sir, to conclude the meet, on behalf of Lupin, I thank all the respected panelists for such a wonderful discussions. Special thanks to Dr. Sreenivas kumar for such a wonderful moderation,
Don't make
and
me
I
chameleon,
request Mr. Prabhu. Sorry, sir.
Okay.
And I request Mr. Prabhu sir to kindly give the vote of thanks.
Yeah, so we have had wonderful scientific exchange, sir. On behalf of Lupin's event, I would like to thank honorable panelists, Dr.A.Sreenivas kumar for a superb moderation, and Dr. Komal for making this interface very informative and insightful. This scientific exchange stands to benefit immensely as physicians start to adopt your perspectives, sir, in their practice. Thank you all once again. Heartfelt thanks from our side, from Lupin's event. Thank you once again.